Welcome to the Ion Annapolis Local Business Spotlight. There are thousands of locally owned businesses in the area, some small and some large. Some you may know and others you don't. But one thing they all have in common is a great story, and we want to share it with you. Join us every Saturday as we talk to the founders, the owners, and the managers of local businesses you have come to know and love, and those you will come to know and love. Now here's your host, John Frenaye, with this week's Local Business Spotlight.
Well, we jumped up here to Evolve Direct and Primary Care again, and we haven't talked to Dr. Freedman in a while because you cured COVID and it's gone.
That's right.
So,
happily cured and eradicated.
Well, I mean, COVID is going to be around for a while, but I think the last time we talked was probably during the heart of COVID. And I know there was just so many different updates coming from the state level and from a medical level. And, when we talked with Dr. Colin Araman and you, and it was, thankfully that's all somewhat behind us and a little bit under control. But today we're going to be talking about a couple different new, treatments that are out there. I want to talk about Ozempic, which is as a weight loss drugs and also a diabetic control.
Mm-hmm.
And we had discussed getting together, and you talked about ketamine working very well on depression. We're going to be talking about it because it is a problem. And, I read a survey, and it was commissioned by some, meditation music website. So figure out what that's, but it was saying that the state with the most depression and anxiety symptoms is Louisiana, with 39.6% of the people polled. And that was a very significant polling thing. Maryland ranked 39th, which sounds good, but still that was at 32.2% of the people have some depression or anxiety. So it's a big problem, it seems. I mean, are you seeing that in your practice?
Enormous. And, certainly the national data is clear that depression, suicide, all of it is on the rise, anxiety. And I find that the number, just throwing a number out there anecdotally from what I've seen in the last, 29 years is A, it's escalating dramatically, but B, I think probably it's more like 70, 80%. I think it's very rare that you find someone who doesn't have maybe not major depression where they can't get out of bed, but I think almost everyone is dealing with some fairly significant level of anxiety, stress, or dysthymia, which is kind of short of depression.
Well, I think it's a different way of looking at things, because I know that we've talked about like autism spectrum,
right?
And you've got the little bit, okay, so he's a little bit hyper,
right?
To the Rain Man guy,
yes.
They talk about that in sexuality too. It's like, okay, so we are completely straight or we are completely gay, and there's just all sorts of variants,
right?
As it slides up and down. I imagine it sounds like it's almost a similar thing with depression, that somebody says, I'm never depressed. I probably lying. At some point, there's something that gets you down. I mean, no, you may not be wowsy woo-wooing all around town and everything else, but it's something that needs to be dealt with.
Yeah, I think that people term it differently depending on their tolerance for seeing that potentially in themselves, or their background, however they were raised, depending on the level of acceptance of mental health issues. I find that if someone is having a lot of anxiety and I say, well, I think I'm concerned that you're having a lot of anxiety, they may bristle at that. But if I say, it seems like you have a lot of stress in your life, people are very quick to say, yes, I do. And
work, school, whatever it may be.
Right. And, it's true that stress causes anxiety, but there's some, I think, overlap in the terminology depending on how you prefer to word that. The other thing is, I think that there is a lot of, psychologists for at least the last 150 years have defined these coping mechanisms, whether it's denial, repression, things that you're intimately familiar with. But somatization is where you feel your stress in a part of your body. And that can manifest as like neck pain, back pain. So, physical pain sometimes is augmented, not caused by, but augmented by psychic pain, if you will. So pain receptors in the brain don't necessarily differentiate tremendously. Is the pain coming from part of your body, or is it coming from, is the volume being turned up by your psychic pain?
Interesting. So, I mean, in the old days, you treat depression, you just sort of didn't, or if it got really bad, you institutionalized somebody.
Right.
It was the I can't get out of bed, and you know what? I maybe prescribed the gave them all sorts of doped them up and let them deal with it the best they can. But we're seeing it evolved into a different thing. I mean, we're seeing, when I always growing up was thinking depression, I mean, I always think it always happens to adults. It doesn't happen to kids. And now I'm sitting here seeing that, there are kids that are obviously suffering from depression and anxiety. And maybe it's just the world that we live in now that as parents, we're putting more pressure on them. Maybe there just generically is more pressure. And I mean, before we recorded, we talked about the bullying and the social media, and there's so much going on in kids' mind. But I mean, what are the ways that you can treat depression? I mean, and I guess how to diagnose it. I mean, that's the first thing. You got to find out whether you've got an issue.
Well, just going back to the first part of that question is, I think prior to the advent of Prozac in the late 70s, 80s, whenever it was that came out, prior to that, there wasn't a lot of really not even half decent treatments. There was the tricyclics and et cetera. And so, and mental health wasn't really considered an acceptable, socially acceptable thing to admit to. So I think,
God forbid you talk about it.
Right. Exactly. So I think a lot of people, in the 50s and back, you come home and, men would kick the dog and beat their wife, and, women would maybe drink too much quietly behind the closed doors. Families would, keep all that stuff very private. You never let the neighbors know or anyone else, let alone certainly not your parent.
Well, that's when you see the news. It's like, oh gosh, they were very nice. We always
right. They just, they go post.
They just borrowed my weed whacker. I don't know, why they snapped.
Yeah, I mean, those are the people that are quote unquote going postal. Were people that are just repressing it too much. And I think as far as the kids go, back in 50s prior, kids should be seen and not heard.
Mm-hmm.
So I mean, there was a mentality that children were not catered to the way we, pay attention to kids now. And, there's been a total flip in, what the focus is on a nuclear family. It used to be the husband and wife were the focus and their success and their whatever.
Right.
Now there's the focus, certainly my family is the kids.
And the family unit.
Right.
As a unit.
Secondary almost. Right.
It's interesting. But I mean, how does depression today and anxiety is it treated? I mean, I imagine one of the first things is just knowing that you're suffering from it, that you are anxious about something, that you are depressed about something.
Yeah.
And I imagine for very mild cases, you can meditation or yoga or something like that probably can help.
Yeah.
I don't think medication is necessarily the immediate answer.
Right. So, it's one analogy that I like to share with patients is, for some of us, for some people, life is very easy, and that they literally walk on water. There's nothing to be worried about, But for most,
it's like my life,
yeah, exactly.
Like your life, right?
Yeah, just
guy who owns a medical practice. What's there to worry about?
Couldn't be any easier. But, for most of us, it's like swimming across the Chesapeake Bay, trying to get to the Eastern Shore. You have to swim across the bay. You have to dodge boats going by, wakes, jet skis, whatever. Depression or anxiety is like tying a rope with barbells to it. Like you can still make it maybe, probably, but you're getting pulled under a lot more frequently than you would be if someone came by and clipped off those ropes. You'd still have to swim the bay, you still have to get across and dodge these things, but it would be immensely easier. So yeah, the first step is, nutrition makes a big difference. Exercise makes a huge difference. Even just walking in the woods is the equivalent to an antidepressant. There are a lot of antidepressant activities that you can do, meditation, yoga. There's a lot of healthy things that you can do. But I've met thousands of people that have come to me and they're doing meditation every day. They're going to yoga every day. They're exercising every day. They're eating really well. And they're still struggling, to the point where they feel that they need something else. And sometimes for years or decades before they finally, bite the bullet.
It's funny you talked about that analogy about swimming across the bay with a barbell tied and pulling you under with the weights and everything else. And I think that taking a step further, when you look at depression, I think you probably, yes, some people make it across the bay with the barbell. Some, get it cut for whatever reason, and things get better and they can get across a little bit easier. And unfortunately, some of them, sometimes the barbell wins.
Right.
And you don't make it across the bay.
Right.
And, that's really where we want to avoid that at all costs.
Correct.
Prozac, I am not a fan of medications in general. I know that, with the hyper kids, it was like, oh, give them Ritalin, they'll be fine. And, send them off. And obviously you can treat with medicine. You can treat depression and anxiety with medicine, and I need to take my Prozac or whatever it may be. But what other alternatives? I know you mentioned ketamine is not new, but it's showing encouraging signs, I guess, in managing.
So for people, prior to for the last 30 years, the only treatments have been Prozac or drugs in that family or in drugs similar to that family, so the SSRIs and the SNRIs, and that was Prozac, Paxil, Zoloft, Lexapro, Celexa, and then SNRIs, Effexor, Cymbalta, Trintellix. Those were the primary drugs that were used. There's tricyclics that go back into, much longer ago, and sometimes they get used, but they have a lot of side effects. There's some augmenting drugs that you can sometimes add to the SSRIs, or sometimes use if someone has failed an SSRI. But for people that have failed, if they failed 2 SSRIs or SNRIs or 2 treatments, medical treatments, medicine meaning, pills, the chance of finding a drug that will successfully treat them is less than 30% ever. And just to back it up for a second, so, the people that you want to treat with medication are people that are not doing well. They're really struggling to get up in the morning. They're really struggling.
They can't make it into work for a week straight. That
not even a week straight. Just a day or two a month. Here and there. And life is a struggle. It depends on. And so with the ketamine and with the psychedelics as a whole, this whole new movement in looking at how we treat things. We've always looked at pathology. We've always looked at taking someone from -10 to 0, 0 being, quote unquote normal.
Right.
But what if you could go from -10, not just to 0, but to +5, +8, +10? I'm not talking about you being euphoric, like you're, in the middle of the Burning Man rave, for like 3 days, but I'm talking about, where you are not only functioning, not only waking up, but actually waking up happy, satisfied, enjoying your life.
Let's get the shoes on and start my day.
Right. But not, or not having so much anxiety that you can't go to the grocery store, or, public spaces is terrifying, or you're avoiding certain things like, everyone gets anxious with public speaking, but,
sure.
People that find themselves avoiding things at work because they don't want to, be in a stressful situation and they can't manage any additional stress. Or they're not sleeping. People deal with insomnia that a lot of times is mainly depression or anxiety. They're just laying in bed thinking about everything that they need to do, or they're thinking about everything that they said that was, wrong.
We perceived wrong.
Yeah. Why did I say that? And
wow.
Or revisiting all these things from your past, or anger that is just constantly percolating and you can't get rid of it.
How does the ketamine come into play to work? You showed me on your way back into your office, you've got a suite, if you will, of looks pretty much like a typical sort of a spa type of a environment, if you will.
Yeah.
But how is that working to help folks that are suffering of anxiety and depression?
Yeah. So in the war in Vietnam, in particular, they noticed. So back up for a second. So ketamine was first invented and FDA approved in the 60s. And it was used for rapid anesthesia. And even in my time, when I was working in an emergency room in Atlanta, It was the primary drug that we use for anesthesia, for rapidly sedating someone that came in the ER that needed to be put on a breathing machine, or, they were kind of going crazy for some reason.
Okay.
So it's been around, it's been utilized for a long time. But what they found was, the paramedics found this, the people at wartime found this, that these soldiers or these people that they rescued from car accidents or whatnot, or even rescued from suicide attempts, that they used it to settle them down, they would come out of this anesthetic state and they would be totally free of suicidal ideation for about a week. So it became, from the Nixon administration, there was a lot of drugs that got high Schedule 1, could only be used for research. It wasn't in that category, but no one was doing therapeutic trials with it for treatment of mental health until Hopkins, Harvard, Yale, and some other major institutions started doing that. And starting about in 2000, they've really started to put out one study after another proving how effective it is. First, it was suicidal, people that were ready to commit suicide or had attempted suicide. And they would give them treatments. And the treatment is usually 2 treatments a week for 3 weeks. So a total of 6. And of those people, after the first treatment, 84% felt that they no longer had a desire to kill themselves.
84%.
Within an hour of treatment. And that effect can last up to a week. Once they go through the induction treatment, that effect continues on for some period of time, as yet to be determined. But there is usually some maintenance treatment that's required, like once a month or once every 6 weeks or once every couple months, depending on how dense things have been for them.
Right. Well, how is ketamine as far as the treatment for the anxiety and depression administered? I mean, is that an injection? Is that an IV? Is it
So there's a few different ways you can do it. The studies have primarily focused on IV. It can also be administered intramuscularly. And there was a drug approved called Spravato, which is a ketamine nasal spray. But those 3 treatments that I just mentioned all need to be done within the setting of medical supervision. So it has to be at a doctor's office or at a ketamine clinic where someone's monitoring you and keeping an eye on things. We can talk in a little bit about what those potential risks are. But there is sublingual ketamine, there's a company called Mind Bloom and some other companies you could log into online and they'll prescribe it for you, and you can pick up these ketamine compounded in these little wafers that you hold under your tongue for, I think, 10 minutes.
Right.
It doesn't have nearly as pronounced an effect, and there's no studies that clearly document how successful that is. Most ketamine experts recommend that you use it as a bridge in between IV ketamine time, as opposed to using it as just the only solution. But there are financial advantages to doing the oral at home, obviously,
sure,
as opposed to coming in and getting the full deal.
Is the treatment, obviously it is FDA approved. No. Okay.
Yeah, so
does that require FDA approval?
No.
Or okay.
No. So it's an off-label use. And just a little background on the FDA and how that works. So if you come up with a brand new drug, like Lipitor or Crestor.
Sounds like a Huey Lewis song.
That's right. And, you're going to make billions of dollars off of it. Then you go through all these research trials. You take it to the FDA. It takes 5 or 10 years or some crazy amount of time and a tremendous amount of lobbying and work to get it through all the process that has to go through to become FDA approved for an indication.
Okay.
And you can only get it for one indication, so like depression. And then if you want anxiety, you have to do the studies for anxiety. You have to do studies for PTSD, et cetera. So most drugs on the market currently, like Benadryl, Tylenol, ibuprofen, things that are generic, are not FDA approved necessarily. And certainly not FDA approved for all the indications of what they're used for. Primarily because it's just, if it's a generic and it's been around since the 60s, no one can make enough money. And so unless the government, through NIH funds the research, which they don't have a lot of money to fund research, and they usually don't focus on getting things quote unquote FDA approved. They focus on proving that it's effective, proving that it works.
That it works.
Yeah.
That makes sense. So when we come here to Evolve Direct to Primary Care, we're hanging out in this room and getting an IV.
Correct.
And I'm assuming this is not nearly as, we're not putting that type of strength out there. I mean, it's watered down, for lack of a better word.
That's right. Somebody's watered it down. So the normal dosing for anesthesia starts around 1 to 2 milligrams per kilogram for someone. So it's considerably higher than what we use, which is we'll start with 0.5 milligrams.
Oh gosh, okay.
And in an outpatient setting where you don't have like an anesthetic, like a anesthesia unit, you can go up to 1 milligram per kilogram, but you don't want to go above that.
And what are we looking for when we are getting the treatment? You mentioned they've got some side effects, and obviously there are some because the rules say that we need to be done under medical supervision.
Right. The primary side effect that we worry the most about is over sedation. So just like going in anesthesia, if you over sedate someone, they can stop breathing. So respiratory suppression is the big one. But what we do is we, have a little ring. It's I should have showed it to you before, but it's a cool little ring that just goes on your finger. It's not even like the standard pulse ox that you get in the hospital, but just a little ring. And it tells us your oxygen continuously and your heart rate continuously. And it sends it to us live so we can monitor you just like you'd be on a telemetry unit at the hospital. And then we also visually monitor our patients through like a closed circuit TV. So we can see if, their oxygen level drops below 88% or
and they're going limp in the chair or
right.
They're freaking out or whatever it may be.
And the other thing is their heart rate can go up too much, or their blood pressure can go up too much, depending on how they're responding or if they've had too much. And again, we can see that and make adjustments.
All critical to be watched for when things go wrong.
Right.
With that,
which is the thing that scares a lot of ketamine providers about the at-home ketamine stuff that's being done.
Is this something that would be covered by insurance at the
no,
or not really? No. Okay.
No. So that's the major problem. And, when we talk about Ozempic too, so if the FDA has not approved it, it's very easy for drug companies to deny it. And even getting the nasal spray, which is FDA approved, and because Spravato it's a unique delivery system as a nasal spray, and they were able to get a patent on the spray and how it's done. So they do have FDA approval for treating depression, but in order to get insurance to pay for it, you must have failed 2 different standard medical treatments like Prozac and Zoloft. And then it has to be prescribed by a psychiatrist. And then you still have to go through these multiple step phone calls from the doctor's office, which it's hard enough to find, it's difficult to find a psychiatrist currently, and then to have someone who's got the time to go through all those steps to get it approved is challenging.
Yeah. Let's talk about the other drug that's in the news now, Ozempic, and I think there's a couple of other ones that are the same type of a thing, and that's that is a diabetic drug,
correct,
and it is now being used for weight control,
correct.
And I know close friends with 2 people on, and they both had completely opposite reactions. One said she was constipated for like going on 3 weeks, and the other one said that she was just sitting on the toilet for like a week and a half.
Oh my God!
So let's talk about this. I mean, is this something that is an effective weight loss drug? I mean, is it magic?
Well, let me draw attention to the transition because both mental health, like depression, anxiety, addiction, PTSD, and weight control are 2 things that people, I think, from outside of the person suffering will look at that and say, why don't you just get it together? Snap out of it.
Right.
Or, why you have this like moral or some kind of, ethical failure on your part, willpower failure to control your eating or to control your anxiety or control these things. And I think what we're really finding between the treatments that ketamine and the psychedelics have been offering And now what we're really seeing with the Ozempic, people that have had lifelong problems with their eating and with their nutrition and maintaining, getting the weight down, are having miraculous results with the Ozempic.
That's awesome. Now, how is Ozempic? Is that an IV type of a situation as well, or is that pills?
No, it's they're injection, but there's subcutaneous injection that you can do yourself at home. And
I couldn't give my cat a shot. I might have a problem with that.
Well, maybe your cat could give it to you. It's a once a week injection.
Okay, and you're seeing great results with it.
Unbelievable.
Is there a cutoff for that? I mean, I know that you've got the BMI indexes and stuff that the powers that be in the government release that are just ridiculously not right.
Right.
But I mean, does there need to be a certain level of obesity where it's either recommended or not recommended, or maybe even more effective? I mean, is it more effective on somebody that weighs 400 pounds versus somebody that is 30, 40 pounds overweight?
Right. I don't know the details about what body mass index, if it becomes more effective at, if you're 400 pounds overweight versus 40 pounds overweight. I do know that the indications are body mass index 27 or higher, which for a 6-foot person, a 6-foot man, I think that's about 185, 190. It's not much,
right?
And it's rare that I think people are at their body mass index for a 6-foot person that it's about, 178 is 25.
Right.
So a body mass index of 27. I think the majority of Americans are easily above that.
Sure, I agree. I agree with that. Now that is covered by insurance.
No.
I thought it was because it's FDA approved and everything else, or is it?
No. So it is FDA approved in some situations for weight loss. And so it's a perfect example. So one drug, Wegovy, is approved for weight loss. Ozempic is not. They are both identical drug, semaglutide.
I hate this.
Yeah. And I think actually Mounjaro is maybe approved now for weight loss, and Zepbound. They're both the same drug, which is tirzepatide. They're both, all four of those brand names are very similar, and they only boil down to two different actual compounds. The Ozempic, the active ingredient, the semaglutide, has been around and FDA approved for diabetes treatment for 7-8 years. So that's an approved treatment for diabetes. And the reason that it has become so widely used is they found that people who took it had suppression of their appetite and improved metabolic numbers and lost weight. The
side effects of diabetes treatment, I guess.
Yeah. So the studies are being done, but the time from onset of a study until publishing the study and then able to use that study to convince the FDA of something it's got to be like 8 years, something like that.
That's crazy. Well, I mean, obviously I think every doctor agrees that, diet and exercise is the key.
Sure.
That's the golden thing, but there is no magic pill.
Yeah.
But everyone's sort of saying that this is Ozempic and the sisters.
Yeah.
Maybe. I mean, how do folks get that now? If that is something that obviously they've got to talk to their doctor, talk to somebody like you and say, okay, well, yes, I think you would be a good candidate for this, or no, you would not.
Yeah. Diet and exercise are definitely the way to do it. But I think most doctors, primary care people would agree that, maybe 2% of people eventually are able to do anything substantial with their weight. And maybe 1% of them, some small number, are able to continue
to maintain it.
To maintain it. Yeah. I mean, people can lose weight, whether it's Atkins or, some fad diet, cabbage soup diet, or, with something, the Hollywood, whatever it is. But then you rebound your weight. And, I tell people all the time, I usually joke with the guys, but I'll say, my goal is not to get you into a wedding dress, in 30 days. Our goal is to get you.
Can you do that, by the way, for the ladies that are listening?
That's right. But yeah, so the Ozempic and semaglutide, brand or non-brand name version, have just been tremendously successful. And the prescription version, which comes in a pen that you just dial up a number and then push it against your side, and it's super easy.
Like an EpiPen or something like that.
Very similar, but much smaller needle and much less spring to the thing. You don't feel it going in at all. It's a 32 gauge needle, and it's tiny. So really no pain per se associated with the shot. Very easy to administer. It's in the subcutaneous fat on your belly, so either side of your belly button, you just, jab it in there, and once a week, you're good to go. The Ozempic is $850 a month at the very best price using a GoodRx coupon if your insurance doesn't pay for it. Wegovy is about $1,400 a month with the GoodRx coupon, and it's a flat price across all the dosing. Compounding pharmacies, on the other hand, can make the semaglutide, and they just compound it with vitamin B6 or a B vitamin, and that, depending on the dose that you're taking, can be relatively inexpensive. When you compare it to that. So you usually start at 0.25 milligrams. You do that once a week for 4 weeks. Then you double it to 0.5. 4 weeks later, you double it again to 1. 4 weeks after that, you go to 2. And that's the final dose.
We've talked about rebound weight on the fad diets and stuff like that. Is that a concern with
absolutely
these type of things? I mean, so if I were to go onto this is potentially an ongoing lifetime type of medication.
Correct.
This is not the wedding dress, and then I can.
That's right.
I can breathe a sigh of relief.
Right. And the studies have all done at roughly 1 year of time. So because it is a new drug for treating weight, even though it's been around for a long time for diabetes, the using it ultra long term is not well known. But what's been very encouraging to me is that the protective benefit on the heart and on the kidneys is so pronounced that Johns Hopkins is putting almost all their cardiac patients on it, whether or not they have weight issues, whether or not they have diabetes, purely for heart protection.
So it actually protects the heart, and you said the kidneys.
Right.
You kind of need both of them, don't you?
Yeah, they both come in handy.
Well, that's interesting. And again, your office can discuss both ketamine as well as Ozempic with any patients. Now, to refresh folks here, you are a little bit of a different type of a practice, which, as I'm finding out, is not as different as it seemed, maybe 5 or 10 years ago.
That's right. When we started 10 years ago, it was very different.
But you are I'll say a concierge type of a practice.
Negative. So,
okay, sorry.
Yeah, that's okay. That's okay. So yeah, we're direct primary care, and it's the primary distinction is between concierge. And so concierge practices, they differ in that they are $2,000 to $4,000, sometimes even more per year. They still bill insurance. That money is purely an access fee, to get in. And what we do is we offer a monthly, membership fee, which is, $59 a month. It's affordable.
Very affordable.
Yes. I mean, it's, certainly less than getting a Starbucks a few times a week. And, anything you might blow money on, it's a lot. It's about the amount, I don't know, they might pay for Peacock or Disney, So, for all your healthcare needs. And that's everything is included, more or less, that you don't need insurance for. Anything that you would use insurance for outside of your regular primary care office, whether it's a CAT scan or an MRI or a surgery or hospitalization, they use your insurance just like they would anywhere else. Just like your primary care doctor is not going to, they're going to send a bill for your physical or for your visit to the insurance company, and they're going to get paid that way. We just don't do that.
I'll tell you, the one thing that I really like about this practice is that when there's an issue, you spend the time needed to talk to the patient.
Yeah.
I remember I had a pinched nerve, but I never had, and I swear to God, I was having the big one. And I still remember you going like, no, it's just a pinched nerve. It's just a pinched nerve. And you're like, you want us to do an EKG? Yeah.
Yeah.
So let's, so it's that, and it's not just a number. And, to see the way the insurance companies and to a degree pharmaceutical companies are controlling the medical industry, to turn around. It's like, okay, you must, come in. No, I couldn't possibly see a doctor. I need a PA or a TA,
NP or PA,
whatever it is, and move it on, and next, and that's not what it is here,
right?
Which is nice, and also that fee does include, as you said, like some of the basic stuff.
And a lot of things you don't get from other offices. I mean, we have antibiotics, which are, almost all of them are free, for any kind of illness that you come in with. We just give them to you on the way out, so you don't have to then go to the pharmacy. EKG and, most of the testing is all included, urinalysis. But I think that one of the other huge benefits and differences between a regular office and what we do is that because we're not fee for service and we're not getting paid by dragging you in here, is if you are on a cholesterol lowering medicine and you get your blood work done and everything looks good, I don't need to drag you in here to tell you what your numbers are. I can send you an email. I can send you a text. We can have a virtual visit. We can have a phone visit. I'm not losing money by being on the phone all day with patients. We're not trying to bring people in to generate business, so to speak.
And that's something else to be said. I mean, I hear a lot of people that are new to town that move in that will say, hey, who do you recommend? And I mean, I hear it on Reddit all the time. I do always recommend you guys, say that it's here. But they're always like, I can't get into a practice.
Right.
It's like there's a wait list. I mean, I got kidney failure. Okay, well, yeah, come on in on whatever. And it's going to the vets too. I mean, my primary cat vet said needs to get like some teeth work done and to go find a
cat dentist.
Cat dentist.
Yeah.
They said, oh, we're not even thinking about new patients until May. And I'm like, but this whole medical industry is like this. I mean, we're finding people saying, I can't get, I just moved here. I want to establish a relationship with a doctor. I can't get in for a year.
Yeah.
Which is nuts.
Yeah, it's awful. And, a big part of the reason is that what insurance has kind of done to the system where now, primary care doctors, you need to see 30 patients a day, one patient every 10 or 15 minutes, and you just need to be churning through people all day long. So a lot of doctors burned out and they either, retired or they went into some other area like non-medical consulting type of thing. Almost all the people coming out of the residency training programs do not choose primary care because it is brutal. It's just
you say primary care within a practice, a larger
training for primary care.
Oh, okay.
So they're choosing to go into ophthalmology or dermatology,
oncology especially.
Yeah. So anything that you have a procedure fee, that's where, the doctors make all the money is, procedure fees. I won't say who said this, but someone very near and dear to me who's a lawyer said, don't marry a doctor unless they have a procedure fee. Yes, that's the joke.
There you go.
So, yeah, I mean, if you, and I saw this in my old practice, I could do a physical exam on someone that had, literally 15 different chronic medical problems, some of which were major: kidney failure, heart failure, liver failure, the list would go on and on. And you would get $35, $50, for that entire visit, no matter how long you spent with them. And keep in mind, your overhead is $100 an hour.
Sure.
So, but if you froze off one precancerous thing off their forehead, that was $90. It was ridiculous. And so it creates a lot of perverse motivation, so to speak.
Well, I agree. And I mean, I remember the last time when I had a physical in here that was, you made a comment about, oh, you got all sorts of crazy stuff going on in your mouth and stuff like that. And so you can go see a dentist. And and I hate dentists and I typically hate doctors. And oddly enough, right now at this point in my life, I actually can say I like my doctor and I like my dentist. So, I mean, this is sort of a weird dynamic that's happening in my life. But when I did tell my dentist that, he said, hey, how'd you find us? And I said, oh, I came here and my primary care said, I needed to get off my ass and do something. He was absolutely floored. He said, because no primary care doctors, according to him, think about that. The correlation between dental health and just everything. I know now it gets into the heart and everything else. So I thank you for that. And my wallet does not thank you, but
right. That's right. That's right. But the focus is, if you're ultra busy as a primary care doctor and you're seeing a lot of people, again, you're forced to focus on the pathology and on the, on the big ticket items, whether, it's high blood pressure, cholesterol, diabetes, whatever it is. And there's not a lot of time left over for wellness, which is just, looking at someone in a more holistic way and thinking about how can their life be better, not just longer, but, actually good, and, keeping them out of the hospital and keeping them out of other doctor's offices. No offense to my colleagues, but,
Right.
Less specialist visits if possible.
Sure. Well, I mean, I know during the heart of COVID with the, the remote,
right.
appointments and stuff like that, it's got to be a time saver and for you, the patient,
But I don't want to wait.
Keeping everybody healthier.
Yeah, we don't want to wait for you to have an angioplasty before we, start getting aggressive, or.
If you were going into med school today, as opposed to 5 years ago, or whenever, whatever it was. But if you were going into med school today, would you still choose a primary care route, knowing what you know now?
If I could come out and do direct primary care, I would, because I've been doing this for 10 years and I love it.
Mm-hmm.
I can say I still love it today. And I love being able to spend time with people, 30-minute visits, 45-minute physicals, just really getting to know people.
Well, the names of your patients.
Yeah.
Which is huge for a patient.
Yeah.
But what would you specialize in if you didn't do primary care?
Well, I was going into ophthalmology. I loved ophtho, and I loved the fact that they made a ridiculous amount of money. I was like, what? It's an easy life, and their surgeries were, seated in the OR. I was like, this all looked good to me. And then I remember in med school, one of the professors asked me, what are you going into? And I said, ophtho all the way, baby. And he said, he just started musing. He goes, why are all the brightest people going into the fields that don't necessarily require the most
the brightest minds?
Right. Because it really is, internal medicine, primary care, that, you have to bring all of this together. And I don't want to offend my fellow ophthalmologists or dermatologists or, other folks out there by saying, because they are the by far the brightest. They're the top of their class. Ortho, they're always the top of the class.
Yeah. Interesting.
But it's much more limited in what they focus on.
Interesting. Well, I'll tell you, we're wrapping up now, and we're also wrapping up flu season a little bit, I guess. Yeah. It wasn't as bad as everyone had thought, I don't think. COVID is still here for good and stuff like that. But what are your recommendations for vaccines? I know that, you sort of went off of the CDC recommendations during COVID for some things, depending on which vaccine it was and everything else. What are your recommendations for just general vaccines for the different age groups now as a medical profession?
Yeah, so I think it makes sense to stay up with the COVID boosters. The last booster was fall of 2023. That was the second bivalent booster. We're certainly nearing the end of the season now, and the end of flu season is usually in mid-March. So we're kind of nearing the end of that as well. If you haven't had them, I'd be remiss to say that you shouldn't go get them. But it's certainly nearing the end of those seasons. RSV was released in May of last year, and there was a big push for a lot of people to use it. But I am going off reservation a little bit on that one because as far as, all-cause mortality in this country, pneumonia, it's like the seventh leading cause of death, but the vast majority of pneumonias are caused by either influenza, COVID, or bacterial pneumonias. And RSV kills a fairly small number, relatively speaking, in this country. And it is fairly localized, if you will, to the very young and the very old, or people with chronic lung diseases or immune system issues.
So hold off on that.
So I haven't been pushing that.
What about shingles?
Shingles, I definitely would recommend it for sure. Anyone over 50, it's a 2-shot series, 1 shot now and then another shot in 2 to 4 months. It doesn't prevent you from getting shingles necessarily, but if you get that lifelong searing, burning, hot poker pain, which some people do after shingles, it's not super common, but if you get it, boy, you'll wish you had the shot.
You had the shot.
Yeah.
Well, as always, I want to thank you for your insight and all the new exciting stuff that's going on here. I can't recommend the practice enough. It's Evolve Direct Primary Care. sandwiched between all the unhealthy places that you want to go. Lita Pizza, the Chinese place, the sushi place, and and there's a Mexican place down on the corner.
That's right.
Right off of Forest Drive on South Cherry Grove Avenue, behind the CVS, and always a wealth of information. I do thank you for looking after me and also coming on the podcast and figuring this out. And anybody that needs any information, you want to go to evolvemedicalclinics.com or come on down and say hello. And it really is a different type of a practice. I mean, you walk into the front door and it's not like a doctor's office. It's comfortable couches, up-to-date magazines. There's a little coffee bar and real friendly people that'll take care of you and make sure that you're the best that you can be. Thank you so much. And till we talk again, I guess.
It sounds good. As always, thanks, John.
Thanks for listening to this week's Local Business Spotlight. Please make sure to visit eyeonannapolis.net for all your local news, events, and opinion. And in case you haven't already, please subscribe to the Eye on Annapolis Daily News Brief, where we bring you all the day's local news direct to your phone, tablet, or computer in about 10 minutes. It comes to you at 6 a.m. every Monday through Friday, and you can subscribe on Apple Podcasts, Google Podcasts, or wherever you get your podcasts.